Well, we had so much fun the first time, we decided, hey, why don't we do it again? And maybe we'll do it 7 more times. So, welcome everybody to the Hospice Emergency Regulation Series, a special edition of At the Table with CAHSAH. We're actually going to do a total of 8 episodes with webinars in the following week, where we break down California's new hospice regulations one section at a time with our experts. My name is Mark Wilson. Let me introduce the experts again right now. My good friends, my new good friends, Sharon Fredericks, and all, by the way, they're 3 of California's most respected hospice experts. Sharon Fredericks, Cindy Hatton, and Eric Peterson. Welcome back. How are you?
Thank you.
Yeah,
Good.
thank
We're
you,
good.
Mark. Yeah, doing great.
So,
Thank
so let me just kind of set the table here before we get into it. Each week we're going to focus on a very specific area of the emergency regulations. And then the following Wednesday, after this podcast drops, there's going to be a webinar, a live webinar that takes the conversation even deeper because we don't have a lot of time in this podcast. So it's kind of cool. You can listen to sort of the flavor of what's going to happen in the webinar, get your questions ready, go to the webinar, ask the questions, and get a much deeper explanation of what's going on. But you'll hear more in the webinar about the specific regulatory requirements and, more than that, the practical implications for your organization. So let me get to what we're going to talk about today. It is the geographic service area / unmet needs.
you.
Now, on the surface, to me, it sounds pretty straightforward. Where do you provide care would be the question. But the real question, I think, might be a little more complicated. It's not simply where you're willing to accept a patient. It seems to be whether your organization actually has the staff and the depth and the infrastructure to be able to take care of those patients safely and consistently, and particularly when it's every day, every night, and sometimes when something goes wrong. So today, let's ask the very important question: how far is too far? So, Sharon, if we could just kind of get started with you, if you kind of broad stroke it for us and kind of give us an idea of what we're talking about here and why we need to talk about it.
Well, I think, Mark, as you said, emergency regulations, but when it comes to your loved one in pain or needing answers on someone to care for them, that's an emergency. And yes, it can happen at 10 in the morning or 2 in the morning. So, um, what we have found talking to a lot of the members and all of us knowing California pretty well in different parts is that there are times where the geographic service area takes a nurse 4 to 6 to plus hours to get to a loved one's clinical needs. So I think that's where, if we look at what has happened, like I'm in San Diego and people are calling going, thank goodness, they are really happy with the regulations. They are finding way too many agencies in LA. And then how do you get the staff out there? How do you supervise them, et cetera? So if you really look at that, it's a geographical service area. Eric's going to give us some technicalities, but it's also then becomes an unmet need. And that's the whole basis for what the regulation is. So they said 2 hours is about it, and you ought to be able to get someplace. And I'm with a very good friend of mine that's actively dying as we speak. 2 hours to me, if I had to call even just RN in the middle of the night, seems like a really long ways away. But I also know everybody doesn't live on the back door. So I think when she called and said this was happening, my first question was, how far away is the nurse from the agency you are choosing? Are we going to be able to have our needs met throughout the 24-hour periods?
So
And
what I hear you saying is then that these new emergency regulations are really kind of
they're needed.
much more specific about what that
Yes.
means.
Yes.
Okay. So, Cindy, let me ask you this. What does the ability to provide care really mean from a regulatory perspective?
I think, as Sharon said, we now have a framework of response time. And as we know, I worked in the Bay Area for a long time, and the traffic was horrendous. And going from point A to point B, the mileage might not be so much, but just the time of day. And so the regulation really spells out your measurements And I think the other thing is it really establishes that 2 hour window that you need to get there in 2 hours. And like Sharon says, our nurses don't always start from the parent office. They could live in another town further away and they are assigned patients. And it might take longer than 2 hours in their house. So that 2 hour window is there. You're going to calculate from your office. But yeah, it's that 2 hour. And I'm like Sharon, 2 hours is too long to wait for the nurse to get there.
Yes. Eric, can an administrator say okay, there's our service area, or does leadership need to demonstrate how the organization determined that area, and can it be safely covered?
Yeah, thank you, Mark, for the question. In the end, leadership absolutely has all of the responsibility to establish best practice. And historically, that's what we were allowed to do. We had sort of a laissez-faire approach to geographical service area. It was being able to meet their needs timely. And so Sharon, being a savvy insider, is looking at not just where does this office sit for this hospice, but where are your nurses employed that work after hours and how close are they actually to my patient or my loved one? Because that is the optimal way in a lot of ways to meet timely needs. You should hire nurses where your service area is and have it in a wide distribution so that way you can be timely to meet all of the needs within your service territory. The regulations now, though, are defining exactly what that means for each hospice. And so that's where you run into this parent office being defined as the epicenter of care. It doesn't mean that you don't have agencies that, are staffed with people at the peripheries of whatever this mile radius is, and they can provide great care or even extend great care beyond that. I think in the end, there were a lot of hospices that overextended their territories, did not staff up well for night on call, and ultimately that's what drove this regulation was that they were not providing good care, especially after hours. So now we've got a 2 hour limit that's based on real time driving patterns and calculations. And you have to take these times, slots or samples within given time frames. 7 to 9 in the morning or 4 to 6 in the evening is where you have to do this snapshot of what would be a 2 hour drive. And then from there, you determine your miles, you take your averages, you get this radius that you can establish. And for some companies, such as mine, the radius that's been provided is well beyond what we typically consider our service area. For other agencies, I think that they're going to be disappointed because they can't include their multiple locations or branch offices. Those are excluded. And so their service areas are going to have to shrink, even if they staffed up the right way. All of those are going to be profound impacts in our industry. And ultimately, it is to help drive and improve those timely response times, especially after hours, because that's where the needs are the most critical, fragile, and ultimately sensitive to meet, especially, in the middle of the night when a symptom onset occurs. That's when families panic the most and need your help the most. And so that's ultimately what we as an industry are looking to meet, and to meet it timely. And so there's a number of other factors that lead into determining your territory. And I look forward to chatting in greater detail at the webinar about those things.
Yeah, again, you're going to go much deeper into these things in the webinar, and then have the ability to take questions from actual providers, not a host like me. Um, maybe Eric, this is another question for you, real quick. And I think a lot of you know that I come from a business development background, and salespeople and liaisons are trained to build relationships and grow census, and sometimes the attitude is, get the referral and we'll figure it out on the back end, right? I'm sure you're all familiar with that. And actually, from all three of you, does this mindset need to change with these new regulations?
I would say
Absolutely.
yes.
Yeah.
I think so.
Go ahead,
Be-
Cindy.
well, because you get your liaison gets a referral. you've got to make sure somebody's looking at it to see how complicated the patient is. Are you going to be able to get DME out there quickly? What about your pharmacy deliveries? I mean, some of these people who are way out, away from your office, how does all of that function? And so, yes, I do think that it affects patient care.
Let me ask this to Sharon. Can a hospice actually grow faster than its operational infrastructure can handle? And when in your experience, what would be some of the warning signs?
I don't even think it needs to be my experience. I think we need to look at what was shown on TV the last few months where the operations didn't exist. And that's why we have, like everybody's been saying here,
Good
we have
point.
24/7 now, and somebody has to be answering the phone, and a licensed person has to be guiding and available for the family until the nurse gets to the house if need be. And we didn't have that before. And like Cindy said, this provides the framework to run really great hospices.
Mark, you're right. You can grow faster. Um, I think the warning signs. Now we also have a limit on case managers, patients, how many they can case manage. I think that has always been a gauge for at least for us when we're staffing. How many patients does each nurse is responsible, the case managers, and when they start moving up and they start getting over whatever your limit is, and now it's going to be 12, or now it is 12, then you've got to say, okay, we have to have more staff. And you have to plan ahead because it's not like you get staff instantly. Uh, Most people have revisit nurses. They can fill in but then that gets into a lot of complications with unions and all kinds of stuff. So, yeah, you have to anticipate this volume increase.
Eric, any final thoughts on that?
Well, I mean, to me, yeah, it's absolutely it's like the chicken versus the egg, right? Like what comes first, the nurse or the patients? And so from a business model standpoint, a lot of agencies, they need the patients to then justify the need for the nurse. That volume of patients is ultimately going to drive, their ability to expand. But also the territory now is a big factor, right? You can't one nurse with 5 patients that are spread all over the world is just as challenging as another nurse with 12 patients that are all in a really condensed location. And so the operations in home health and hospice are just highly intricate, highly challenging, and ultimately are now being kind of guided through these emergency regulations to have best practice established. The 2 hour time limit, I think, is very fair. I think that ultimately, if you really look at it, to go from one area of your periphery to the other is really a 4 hour drive. So, how are you staffing at night to still have operational control to meet patients' needs? One nurse may not be sufficient if you're going to maximize your geographic radius, right? You need maybe two so that way you can meet them if the needs are at each end of the spectrum. And that's where I believe, ultimately the ratio that's being, outlined in the emergency regulations, the patient acuity system that needs to be developed to guide ultimately your staffing, both for day and night, are all pushing the industry to have adequate staffing and the needs to be met consistently and to review your deficits from meeting those needs,
Mhm,
right?
mhm.
The patient acuity system has to be reviewed annually, if not more frequent. If you don't see someone within 2 hours, which is the requirement, right, by a nurse, not necessarily an RN, but by any
And I believe that's the patient acuity thing is something that we're going to cover again, a separate podcast and
it's
on
a
a separate
separate
webinar.
conversation.
Eric,
Yeah.
Eric, I have just a follow up for you on this, and I'm really not trying to be negative Nelly here or find things that are going to be bad, but I think again we have to acknowledge the realities of rural California. And maybe it's because I grew up in a rural area.
Mhm.
Um,
Anywhere you want.
some communities already have limited access to hospice care, and if agencies have to become more cautious about geography, is there a risk that rural patients become even harder to serve? and maybe they won't have as much access as they do now.
I think that's a fantastic
Absolutely.
question. And, for some of those areas that are being serviced by larger corporations that have multiple locations, there will be the potential for those areas to not be as well covered. But right now, what ultimately Medicare and pardon me, California is really only going to allow once the moratorium is lifted, is you can only be a new agency that applies to cover
Hmm.
regions that have what's called
Hmm.
unmet needs,
Yes. Thank you,
right?
Eric.
And so
Hmm.
the unmet needs calculation is something that there's, I believe, 25 counties right now. I might be wrong with the exact number, but it's listed in the emergency regulations that are identified as rural. So all of those counties, if you're going to look to open up a new hospice, that you can start with those counties. The calculation to determine unmet needs in every other county that's not already identified as rural is kind of a complicated math trick, um,
It's a whole
and
nother seminar.
and
Yeah.
that's what we'll be
But Eric's
covering in
gonna give
detail
you
in the
that.
webinar. Yeah, yeah. So you have to prove though that this county that I'm in, has an unmet need, and that's what allows you to service it. This is all.
But I still wonder if people are going to be so cautious because there's so much going on. I mean, they're really going to have to be educated and really understand
Yes.
these regulations in order
I
to be confident.
Absolutely, absolutely,
I'd
and I
like
think
to ask
specifically
you,
the
Mark. Oh,
strength.
sorry, Eric. Go ahead.
I was just gonna say the
I'd like to
strength of
ask
your
Mark, since
coffee
he's been in
department.
business operations, what would be how much education would you think you in business and your liaisons would need to get through all of this?
How much? You
Well,
know, uh,
more than 5 minutes, I assume.
more than 5 minutes. Definitely some sort of a structured educational course. And I think that in
There you go,
particular,
Sid.
sometimes the liaisons and the marketing and the salespeople kind of get left out of the equation. They're just supposed to go out and get the patients, and that's all we care about. And listening to you three, I'm wondering now, and that's a great question, Sharon. I think that it's something that as a business development executive, I would want for my team because I think they need to be working synergistically with the rest of the team and to set expectations, not
Mhm,
just with the sales staff, but I think with our referral partners. You might refer a patient to us that we aren't able to service because of these regulations. And I think that's the worst thing that can happen in sales and marketing is, what do they say? Don't promise. It's not the
Yeah,
promise, it's the deliverable.
yeah. Under
Think too,
promise,
Mark,
over
from a
deliver.
sales standpoint, for us, we've always, in my career, we got patients that we weren't able to take. And so for us, it was we felt our responsibility to help them or give them, okay, here are the agencies that are serving your area. Because if it's one of these areas that you don't cover, then you should know your neighbors. And so you should be able to give them some options. Because if you give that referral back to the hospital, they're not going to be happy. But when you call the hospital back and say, we are not going to be able to service this person, but we've given them 3 names and they're going to let you know who they picked.
Yeah, it's a safety issue, patient safety issue, nothing else.
mhm.
Correct.
Well, and we've been talking a lot about night on call and ultimately your general territory, but we shouldn't forget as an industry that we still have to admit this patient within 48 hours and get our entire care team out there within
Mhm.
5 days. So,
Right.
what is your ability, right, is going to be, it's going to fluctuate for each agency. And so I think ultimately doing things and putting the patient first is what's going to position your company to be well received in the community, provide great service, and to ultimately grow. It's driving quality, not volume, and I think that's really what is the benefit of this regulatory change. And one comment, like a lot of companies, I think the big ones are going to read this and be really dismayed and frustrated. The smaller ones are like, we're doing it right, and maybe ignore this whole calculation.
Like
But
that.
I wanna just caution everyone, like, to me, the ethical intent of this section of the new regulations is so critical. It's actually kinda simplistic to put together from a policy and a procedure standpoint, and just, check the boxes, and do what's right, and be prepared for when the surveyors come in. They're likely going to ask you for this exact
They
item.
will.
I see this as being a
Yes.
high priority for the surveyors coming in because it's what's right, you
Well,
know?
and let me go to the webinar that's coming up too, because what it sounds like to me is that this is doable. So there is hope.
Yeah.
and and you're going to teach people in this webinar or give them some tools and some ideas on how to balance those regulatory expectations with what's going on in the real world where they live. Am I correct in that?
Hmm.
In a lot of ways,
Absolutely.
absolutely, yeah. Your QAPI and
Right.
your compliance department are ultimately gonna be what's gonna sustain you as far as looking at the deviations from, maybe non-compliance, right, for a lack of a better term. The goal is to get there within 2 hours. The truth is you can't predict, that you're gonna have 3 or 4 people all call in with a symptom burden that happens at the same time. So the strength of your team to investigate and learn from those circumstances is what, to me, is ultimately the best practice for long-term success. So
Yes.
building it is the easiest part, sustaining it is the harder part, and investigating deviations is where, the rubber meets the road for improvement.
And
And
I
I
think
would
your
say
surveyors will be doing that. Go ahead, Cindy.
I would say for the small agencies, I always think of the small agencies. Eric's got a very step by step approach on how to figure this out. And so it won't be quite as burdensome, even though there's a lot of steps. So he'll make it as simple as possible. But yeah, I mean, the small agencies have to do the same thing. So we always think about them.
Okay, we're getting ready to finish up here, and I feel like I could go for another 2 hours, but I think that's what the webinar is all about. So,
Thank you.
but I like to always end with sort of a practical thing. So let's do that. Let's make this really practical. If I'm a hospice CEO, administrator, or a clinical leader listening to this podcast, I want to know what I should be looking at when I walk into the office tomorrow morning and go.
I would say you're staffing for the day. I mean, you have a director of patient care services who really is the one who's looking at that, but I would check in with them and just find out how staffing is going. And, how many call outs, that's always the big challenge for people, but really making sure you have enough staff for the day who can handle, like Eric was saying, anything that happens anytime, day, night.
Yeah.
Okay, Eric.
I think really focusing on your night report, making sure that you're aware of when someone is calling in and ultimately how their needs were met, whether
Absolutely.
that was a telephone call with triage or an actual visit. Make sure it's all documented and make sure that those folks are being seen in under 2 hours. And you should investigate anything that's beyond that 2 hour limit. And start with the practical aspects of your daily and nightly operations to make sure that you're sufficiently staffed to get there in less than 2 hours. All the rest of the details we'll cover in the webinar on ultimately how the policies need to be developed and the details to calculate it. And I think that's your quickest way to understand where your needs and improvement opportunities might be.
Sharon, what about you?
I just think exactly expect that you're going to have times where you don't meet that 2-hour timeline, and those should be investigated and why. That's to me what the surveyors are going to be looking at, especially in the beginning here till we get all this figured out. But back to what you were saying, Mark, as far as your liaisons and marketing, right now you need to at least kind of anticipate what a 2-hour time frame would be until you really do the calculations. And the other thing that's in the regulations is even if you've put in the application, you're fairly soon when applications and the moratorium's off, we can do that. You can't be changing geographic areas without filling out forms to the department. And you cannot be advertising where you might be going until it is fully approved by the department.
That's a great
So,
point, Shane.
Okay. Okay, great. We got to wrap it up. So let me give you just my takeaway in all of this. Geographic service area isn't simply about drawing a line on a map. Sounds like it's about making a promise that when you admit the patient, your organization has the people and the systems and the clinical capacity to care for that patient. And California's hospice emergency regulations are making the geographic service area a conversation that belongs at the leadership table. So if today's discussion raised questions about your organization, and I'm going to guess it probably has, CAHSAH is continuing the conversation again Wednesday with a live webinar where you can speak to our 3 expert guests, and it'll be focused specifically on geographic service area and unmet needs. And again, the webinar will go much deeper into the requirements and the regulatory details and the practical implications for you as hospice providers. And most importantly, maybe you'll have the opportunity to participate in live question and answer sessions. So visit CAHSAH.org to register yourself. That's CAHSAH.org. And then join us again next week for the next episode in our California Hospice Emergency Regulations Special Series. I think next time we're going to be talking about policies and procedures. Is that right?
Yes.
Yeah.
Please. Yeah.
Okay.
Yeah.
All right. We'll look forward to that. I always look forward to speaking to you 3. This special series is presented by the California Association for Health Services at Home, CAHSAH. I'm Mark Wilson, and for Sharon, Cindy, Eric, and everybody at CAHSAH, thank you for joining us today at the table. We'll see you next week and at the webinar on Wednesday. Take care, everybody.
It's good.
Have a great evening.
Bye.
Thank you.